Our young doctors often get confused when they come across a case at hospital. Though they have the knowledge of disease, but they find it quite difficult to apply that knowledge practically. But sqadia.com is always there to help young doctors. So we are discussing a first case related to nucleotide metabolism that may help you in diagnosis when you come across a similar case in a clinical setting. So here you go. A 2-month-old male infant has been referred to your pediatric genetics practice for failure to thrive and repeated infections. Over the last month, the child was admitted to the hospital twice for the treatment of bacterial and viral pneumonias. While hospitalized, the child was found to have a significantly decreased lymphocyte count. The child's older brother and older sister are in good health. However, a paternal aunt died before the age of 1 as a result of repeated illnesses. You suspect that the child has an immune deficiency and will not be able to survive past his first birthday without aggressive treatment. You inform the concerned parents that the child may need a bone marrow transplantation, and you raise the possibility of experimental gene therapy. So the probable diagnosis is an autosomal recessive disorder that results in a defect of adenosine deaminase, or ADA. The pathophysiology of the condition is that we have already discussed in our video on purine metabolism. If you recall the purine degradation, where ADA is involved in converting adenosine to inosine. When ADA is deficient, adenosine accumulates because it is not converted into inosine anymore. This accumulation of adenosine eventually results in an excess of DATP, or deoxyadenosine triphosphate. Now, what does this DATP usually do? Well, it serves to inhibit ribonucleotide reductase. So, ribonucleotides are not reduced to deoxyribonucleotides. Hence, DNA cannot be synthesized. Now, this defective DNA synthesis results in deficient lymphoid differentiation and results in dysfunctional T and B cells. Adenosine Deaminase Deficiency accounts for half of the autosomal recessive cases of severe combined immunodeficiency, or SCID. And what does immunodeficiency suggest? Obviously, lot of infections. Same as we saw in the child whose case we are discussing. So, SCID is associated with severe and repeated fungal, bacterial, viral, and protozoal infections during the first year of life. The disorder commonly presents with pneumocystis carinii pneumonia and failure to thrive. Pneumocystis carinii pneumonia is a fungal infection of the lungs. Graft versus host disease will often develop after transfusions. Now, what should be your approach to this patient? Well, the treatment option you have is bone marrow transplantation as a source of stem cells, or administration of exogenous adenosine deaminase, AD, conjugated to polyethylene glycol. That may improve immunologic function and clinical status. AD used with limited success. Unfortunately, affected infants rarely survive beyond 1 year without treatment. So here is a summary in the form of a flashcard of adenosine deaminase deficiency. That concludes our video. We will be discussing 2 more case studies related to nucleotide metabolism in our upcoming videos. So, keep watching.